So welcome to another brain building session. These are the sessions that are sponsored by our UF Brain Center. That is the Brain Injury Rehabilitation and Neuroresilience Center, which brings together a wide variety of investigators for all forms of acquired brain injury, from anoxic to traumatic to vascular, and so anything that is acquired. It's been quite a community that's been building and coalescing around this. And so when we have these brain building sessions, they really focus on collaborations and different perspectives, which is really what the center is for, is to kind of build that kind of community. I'm really excited about the talk we're going to hear this afternoon. I know a little bit about it, but it really involves collaborations with multiple specialists, collaborations with multiple sites. The goal of research that we all do is to find translation for clinical application and improving the care of others. This particular project actually does that in spades by also having some public policy implication as well. It's very important issues affecting the country. And so we have two of my favorite people who will be speaking this afternoon. And so one of which is Katarina Bussel, who is our division chief for our Division of Neurocritical Care in the Department of Neurology, and Carolina Maciel, who is our Associate Division Chief for Research in the Division of Neurocritical Care. And she has assembled quite a big team to do a lot of the building up and really from scratch over the time they've been here to a very powerful engine of neurocritical care research, which is doing great things and is poised to do even greater things in the future. And I think you will have that feeling too, doing that. As usual, we usually have a lot more people who are online, and that these sessions are taped for people to watch in a time-delayed fashion and will be posted on our website. And without any further ado, I will then hand it over to the dynamic duo.
Thank you for the introduction. And I wonder, Jessica, are you monitoring a little bit the chat? Because sometimes it's challenging.
Yes.
Wonderful. So then we'll do that. And go right ahead. So we're excited to talk about one of our main projects here, which is to utilize a pterygopalatine fossa block as an opioid-sparing treatment in a novel approach to address headaches in patients with acute subarachnoid hemorrhage. And I think one of the things from the get-go is that headache is not classically something that is addressed in the intensive care unit as commonly as perhaps needed for neurologists and neuroscience to think about. Our disclosure is that this is a NIH NINDS funded UO1 trial, and we'll delve right in. So for who has not been an intensive care unit, this is what we see commonly. And for who is at UF and knows the beautiful tower our neuro ICU is in, will know that it's bright, it has lots of windows, and yet our patients that are afflicted with subarachnoid hemorrhage do not utilize. They in fact want the opposite. They want a dark room. So we go along the hall side and you see the blinds down, the curtains pulled, and patients miserably in bed because their headache is really bad. Post-subarachnoid headache is near universal. It nearly affects everyone, at least 90% upwards in the first few days. It is very severe, it is relentless, it affects recovery, and it may become chronic. The etiology and the mechanism for post-subarachnoid hemorrhage headache is complex and is multifactorial. There are blood breakdown products. This is from the bleeding that happens with a subarachnoid hemorrhage. Blood sits in the subarachnoid space and is being broken down. There's iron products, there is hemoglobin products, and many of those induce an inflammation, an inflammatory reaction. However, there's also, independent from the blood products, a body-guided, innate immune system and inflammatory reaction that's being triggered by the critical illness of that nature. There is disturbed vascular autoregulation, which affects both large and small and medium-sized brain vessels. There is at times elevated intracranial pressure, which may have to do by a pooling of cerebrospinal fluid, too much cerebrospinal fluid, inability of CSF to flow off or drain off, or by cerebral edema. So that alone is multifactorial and multi-etiological. And then there is the concept of cortical spreading depolarizations, which is essentially a response of neurons and their surrounding to alter how the electrical response goes and the waves of electrical flow is happening in simple terms. Carolina is probably gonna want to correct me later on how I just defined that. It is important to know that post-subarachnoid hemorrhage headache is very heterogeneous, both intra and interpersonally. The pain perception can change and be very different from person to person. Pain trajectories have been described as very different, can be starting off mellow, become very severe, more often starts very severe, stays severe, or can mellow on as time goes on. That's at least the hope, and that's what we're striving to do. And then response to medications and treatments is very different. And you can see I have two pictures here that have a variable amount of blood and other etiologies. The left one has a lot of very dense cisternal and central blood. The second one has a feature of hydrocephalus with elevated size of the ventricles and then more cortically spreaded blood. And the problem here is that from neither of those can you deduct at all how the patient feels. Now, coming back to the point that post-subarachnoid headache is relentless, there are a multitude of single-center trials that looked at this. So while the setting hasn't ever been described well in a multi-center or randomized trial, the cumulative data from lots of variable single centers is quite convincing, among those our own. So the first one, yellow picture, you can see really that the pain scores in that series from Maine started off between 6 and 8 red and blue curves. And then over the 14 days, which is the classical duration of hospitalization, stayed pretty high up, above a 5 at the median, which is still moderate severe pain. And then the maximum amount lingering in the 7 range, which is the definition if using the numeric pain rating scale score for severe pain. The middle graph is from our own data, which essentially shows very similar, calculated a little bit different, but you can see in panel A that the pain maximum curves at least once a day reaches between 6 to 8 for most. And then even averaging pain-free hours, you still are constantly in pain on average. And then the third one is another series that looked similarly at time course of pain scale scores and maximum pain. And shows that the percentage that falls into the 10 range is the highest. So pain is bad and it's relentless.
So we have really this ubiquitous problem, right? It's actually so bad that the hallmark of subarachnoid hemorrhage is having the worst headache of life. And I wish I actually tested this before, so I know where's the pointer and there's no pointer. Okay, so that's why it was a good decision not to hijack her presentation. To point. All right. So in order to then translate this into a clinical trial, you were studying something that everybody experienced. It is profoundly impactful, patient-centered problem, right? But then how do we manage pain? Like, this is something that is so much variability in how a clinician approaches pain management of any type. A pain that it is acute in someone that is critically ill in the neuro ICU, it is a pain that sometimes you cannot really afford complete comfort or complete relief of pain because there are so much requirement for analgesia that the toll that it takes for complete analgesia, it might be too much and lead to other complications. So when we were designing this study, we were like, okay, so we need to first figure it out. What it is actually commonly used? Do we know how clinicians, how Yvonne approaches the patient with pain in ICU? How does that differ from how he manages a subarachnoid hemorrhage patient? Do they manage patients with subarachnoid hemorrhage in headaches all the same, no matter how severe, how many risk factors for complications? So we knew that if you were to tackle something that it is so ubiquitous, but then also clinicians will have differences in preferences in how to approach, we needed to account for that in the setting of clinical trials with some sort of standardization. But we also want to find a standardized management for this headache in a way that will be widely accepted, needed to be pragmatic. So then we delve into the literature to figure it out what is being used. And not a surprise that acetaminophen or paracetamol in other places in the world is called 90%, right? less likely to cause sedation, liver problems. It's not super potent analgesia, but widespread availability. Everybody's comfortable with it. So most likely used. But in 2/3 of patients, actually, we are using opioids despite the gamut of side effects the opioids come with. Constipation, nausea, right? Sedation, the risk of addiction. And that is, thank you, Mike, for bringing it up, this important point, because it absolutely has an impact of our study and strategies, right? For any condition that we can mitigate the use of opioid as a nation. And corticosteroids, anti-inflammatory, Katarina delved into the multifactorial pathophysiology of this pain with inflammation as a component. So it's natural that we would think about that with corticosteroids in about a third of those patients. And anti-seizure medications, just because some of them have analgesic effect, in particular headache management, such as valproic acid, pregabalin, and gabapentin. So other options, as we pointed out, gabapentin, pregabalin, dexamethasone, corticosteroids, and multimodal systemic management. And this is something that we know in analgesia management is always great to use little doses of many different, so then we buy less effect, and we have a higher likelihood to target this multimodal mechanism of pain generation. But the problem is that, okay, so you have all this arsenal. Why do you actually need to study this? Well, analgesic failure, sustained pain, that it is significant and potentially impactful, it's still in 2/3 of the patients. So we are failing the majority of patients that we are admitting and caring. Now, that comes with other implications of other complications in subarachnoid hemorrhage. This is all over the place, and that is to make a point that everyone has an independent trajectory and shows the heterogeneity of pain trajectories in the patients with subarachnoid hemorrhage, which now if you switch from a clinician to a researcher, you're like, okay, every time that I have, right, basics of sample size determination. If I add variability, I need to, right, I have a challenge in detecting the effect size. Right? So then this, we were already thinking one more reason. We need to control everything that we can control in the design of this study. So you're seeing this heterogeneity of pathways, but uniformly, if you can actually decrease the noise, put that in the background, what we are seeing is exactly what Katarina is telling us, that severe pain is commonplace, right? And then who cares? Well, we care because they are uncomfortable, but we also care because it has actually systemic implications. Those patients have a very low sodium. And why is that? What does it have to do with this? Cerebral salt wasting? Well, maybe. It can also be that inappropriate syndrome of release of ADH, our hormone that makes us to hold on to water, and that leads to sodium dysnatremia. So then it is an abnormality of sodium level. And you can see that there is an association between, if you dichotomize the severity of pain, patients with worse level of pain end up having worse problems with sodium. Now, you can see here that perhaps clinically this difference, is it really different? 136, 138, is that clinically impactful? This study does not tell at all, because what it takes actually to maintain sodium in normal levels, it is not reflected in this data set. So it could be a lot more resource consumption, giving a salt load to those patients, give exogenous hormones like fludrocortisone to try to control this. And all these, again, come with other costs in a patient that is critically ill, and every single factor counts. All right, so we talked about it, and I hope we brought home the point of how impactful this is. And you end up having a lot of data demonstrating like in your face, the impact of this. Actually, post subarachnoid hemorrhage, headache is one of the leading causes for coming back to the hospital afterwards, just second only to stroke and hydrocephalus and sepsis, okay? You have higher use of sedating analgesics, you have increased use of neurodiagnostics because a headache could represent other complications that are life-threatening and feared in subarachnoid hemorrhage, a potential increase use in invasive procedures, and those patients are unwilling to move, to participate in rehabilitation because they are miserable, or they are not in pain and they are sedated and cannot move because of the analgesic use with opioids. So we got to do something new. What we have is a lot, but it is not enough. And then we brainstormed with a lot of collaborators here. It started off actually in a discussion with our neurosurgeons. They're like, oh, they come back in clinic all the time with this headache. And I don't know, I'm not a neurologist. I do not know how to treat these headaches. Can you guys come up with something? And then we said, yes.
So this is a collaboration that it is transdisciplinary among mostly bedside, but also some translational people. So Brian Ho, the chair of neurosurgery, does both bench research in subarachnoid hemorrhage and aneurysm formation. Then you know Carolina and me by now. And then the fourth multi-PI is Dr. Cam Smith, who is a pain anesthesiologist here at UF, does acute pain, and really has spearheaded a lot this procedure that we introduced in this trial. So just to provide an overview, and the QR code goes to our published trial protocol. BLOCK-SAH is a phase 2 multi-center randomized double-blinded placebo-controlled clinical trial with the main purpose to assess both efficacy and safety of a pterygopalatine fossa block, abbreviated PPF block, to mitigate opioid requirements and improve headache control in patients with aneurysmal subarachnoid hemorrhage. We designed this as a sequential parallel comparison design trial, and we'll come back to that in a little bit. And then the intervention, which is the star of this trial, is a bilateral PPF injection with either 20 milligrams of ropivacaine and 4 milligrams dexamethasone. These are typical components of a nerve block, for who may not be familiar with nerve blocks. And that's the active block, or compared to saline injection, which is a true placebo injection, as opposed to using a sham or let alone like a pseudo sham even. We monitor our patients and participants clinically through pain medication utilization, pain scale scores, among others. And then importantly, and this will be delved into detail by Carolina in a little bit, through transcranial Doppler monitoring, ultrasound of the intracranial vessels to monitor flow velocities in the circle of Willis, pre and post procedurally. Our study population is 195 survivors of aneurysmal subarachnoid hemorrhage during their hospitalization and during the ictus hospitalization, meaning when their aneurysm broke and they're just being admitted, so early during the course, in 12 neuro ICUs in the United States. Our anticipated study duration is 4 years in total. We are through the startup months and we are in the enrollment period with the hope to then, after completing enrollment, close out, follow up, and then data lock and analyze. This is a visualization of what, from a study practical standpoint, our participants go through. So at point 0, they have onset of subarachnoid hemorrhage. This starts their eligibility period, which spans 96 hours. This equals 4 days. And the reason why this is early on is that when subarachnoid hemorrhage occurs with an aneurysm or rupture, the processes that I briefly mentioned earlier all kick in. This may lead to secondary injury, which is particularly important in subarachnoid hemorrhage and called delayed cerebral ischemia, and essentially consists of all these various mechanisms that are also in part, or at least in variable amounts, responsible for creating the headaches. They're also creating these secondary processes. So then patients are admitted to the hospital, usually fairly early on because it is excruciating and they're very sick. Their aneurysm gets usually secured within 24 hours, which is the guideline recommended expedite surgical management with either coiling or clipping. And then that would conclude the eligibility period at the end of 96 hours. If patients enroll, they will then go for a first injection that starts off the double-blinded period, which is 2 days of PPF injections with either placebo or active block. And then that can be followed by a guaranteed open label block that we introduced because of the specific SPCD that we will go into a little bit later in the slides. But to take it ahead, that design might mean that patients get placebo. So then in order to avoid only placebo and guarantee anyone that has a headache and would want to go for it, they can opt for an open label block. And then that is followed throughout hospitalization. And as mentioned previously, these patients stay usually in the intensive care unit for 10 days, at the least up to 14 days on an average. And then that allows for us to be practical from a trial perspective as well, because they are in the hospital. So there is no such thing as losing to follow up in the early immediate phase. And then we have one potentially virtual 3 months follow-up visit, again, allowing for highest practicality and avoidance of a loss of patient follow-up. Now, I already mentioned the pterygopalatine fossa. So the pterygopalatine fossa contains the pterygopalatine ganglion, also referred to often, or you might remember from your anatomy, as phenopalatine ganglion. It is the largest ganglion of sensory, sympathetic, and parasympathetic nervous system. It gives rise to the greater and lesser palatine nerves, nasopalatine nerves, superior, inferior, posterior, lateral nasal branches, and the pharyngeal branch of maxillary nerve. So that would be V2. And you can see the graphic is utterly confusing. It's busy. This is a busy place for nerves and nerve traversion. It is important, right? So there's many. And hence, people figured it out a while ago that this particular ganglion plays a central role in the generation of trigeminal cephalalgia. And this has mostly been explored for migraine cluster headaches, if we talk about primary headache disorders, but also in secondary headache disorders such as post-epidural puncture headache.
So Katarina is saying that if we modulate that thing that is deep in the face, we could potentially avoid treatments that have a systemic side effect. But how do they get there? Right? Because it is deep in the face. So through a PPF injection, a guided injection that you're actually going to target the key structures, nervous structures of headache generation, of pain generation, regardless of the mechanism of pain. Because we talked about that this is multifactorial. So if you are addressing a specific pain component, you do not know if that is actually going to work out in every single patient that has this type of headache, which can have an imbalance between which mechanism is actually the most predominant. So then the main structures that we are targeting in the pterygopalatine fossa is the maxillary nerve and palatine ganglion, as we're seeing here. The ultrasound probe in green here is demonstrating that, well, to get there, we want to do it safely because it is a big needle in the face, and we want to do this with direct visualization. And then we can do either placebo or active. Both are solutions that are just transparent, 5 cc's, so it is completely blinded. And then with the constituents of the actual active injection with 20 milligrams of ropivacaine and dexamethasone, which you recall, we mentioned about dexamethasone before, but that is in that context of taking systemic. This is local, so we avoid systemic side effects from this. Now, it takes some preparedness. And then again, it sounds potentially scary that you're coming to my face with a needle and inject things and something potentially behind my eye. So what it takes is proper positioning, gathering everything. Look at every single step that it takes to actually do it in a systematic way across 12 sites. Remember this is not something that everybody is doing every day in your life. So we need to train people to do it. So you need to have a systematic approach, standardize every single step, and make it actually visual. I want to also point it out that what it takes, because this is not just really pointing it out, the scientific aspect in terms of the biology of things, but also the pragmatic aspect of implementation science, right? How you're going to design the study and actually be effective in conducting this study when you're doing something novel that has never been done. And then we decided the visualization of the graphics demonstrating actually what everyone should be seeing in every step of the way. So then it is a cue for the investigators, for the proceduralists to actually keep that in place and appropriately position. So next slide, please. And then I got it myself, right? To just really see how it feels. And then I am actually able to really reassure that it wasn't that bad. So yours truly, as you can see here. So proper cleaning, because this is an invasive procedure and you would like to make sure that there is no obstruction of infection. The area is demarcated, so then we know exactly what was clean. And then you were just, this one is already injected, a proper, the needle is positioned, and then with visualization of the ultrasound. And this is delivery of the injetate, and we can see on the ultrasound if the needle placement and the injetate is actually in as appropriate, as adequate as it can be. Because again, switching hats into leadership of study, we need to actually demonstrate it. If at the end of the day, our study was not able to demonstrate the intended clinical effect, was it because it was not done properly? Or was it because the intervention does not work? So then we are collecting actually ultrasound images of every single block, or I should say injection placed, and centrally analyzing with adjudication by experts in a blinded independent way to demonstrate, actually for two purposes, to demonstrate whether or not it was appropriate or not. And in addition, it's improving technique, giving real time. Every single enrollment, the proceduralists have an opportunity to really refine their techniques. Now, we also talked about the TCD monitoring and why is that about. So this has also never been done in subarachnoid hemorrhage population. Katarina mentioned that this intervention is associated from cluster headaches, from other outpatient chronic headache disorders. And one of the major problems of having blood products in the subarachnoid space, where there is this location where all the cerebrovasculature, the major cerebrovasculature exists, is that the blood there irritates those vessels, these arteries, and make those patients prone to vasospasm or stroke. Now, there is also a lot of important structures there, which we're going to go into more detail, that also modulate the cerebrovasculature. So BLOCK-SAH study gives us an opportunity in a systematic way to demonstrate, regardless of the opioid effect, forget about headache, but if we are systematically modulating, either with placebo or with active injection, the structures in this fossa that we know can have vasomotor potential of like modulation, what could that do? Could that actually be helpful in the future for something else? And meanwhile, we want to make sure that there is no risk for an increased complication, particularly the most feared complication of subarachnoid hemorrhage, which is vasospasm and stroke. So then what we do is before the procedure, 3 hours, we want a baseline, and then after the procedure, within 3 hours, we are comparing pre and post because we know that this is a dynamic state that can change.
So Carolina mentioned this earlier already. For the purposes of the trial, we need to institute management of headaches that is standardized across sites. And so as also Carolina went into detail, we base this standardized protocol very much on what around the world is really done most commonly. And this is Tylenol, acetaminophen, or paracetamol, opioids. NSAID sometimes, more rarely, but then the anti-seizure medicine class, gabapentin, pregabalin, magnesium has had a big track record in headache and subarachnoid, both with little effect, honestly, on severe headaches, but nonetheless. And then others. So we try to be very generous and flexible to make this not a protocol that then would not at all be generalizable to practice. However, glucocorticosteroids, dexamethasone systemically is not allowable for the purpose that we specifically want to try it localized. Plus, it has actually a really poor track record in subarachnoid hemorrhage with only 3 trials looking at that. And those were observational, I should not actually say trials, but observational studies with very meager effect. And then other management strategies such as opioid pump. Other blocks, of course, or Botox injections are not allowable for the purpose of the trial, and I should say are not very widespreadly implemented either.
So the point is, we really needed to actually get everything that we know it's been thrown at those patients together, right? And figured it out what regimen we would say, this is okay, this is not okay. But this is maybe this is okay later if, right, if the patient is still in pain, but then not right now while we are actually looking at the studies, right? You want nothing that could potentially make it worse. You don't really want so many things allowed because of the heterogeneity that you are adding to the data set, and allow for the ability to measure the impact that you want to measure. So then you need to have some mandatory baselines. So to demonstrate that they are starting from the same way, no matter if they are UF or if they are all the way on the other side of the country. Yeah.
That's exactly how it is. And yet, nonetheless, this is so broad, as you can see, and seems complicated. It is tricky to have a standardized management that is practical. I mean, that's definitely something we're learning more as we go along.
Fun fact, we revised this table about 5-10 times.
So coming back to the sequential parallel comparison design, it is a neat design that has not been used in ICU trials before. And what this design that really came about in at the clinical trials group from the MGH that looks mostly at pain and or psychiatric trials is to introduce a third group that is placebo-placebo in addition to the more conventional active placebo and placebo-active arms. And the third group, the placebo-placebo, will mathematically reduce very substantially sample size needed because it weeds out between stage 1 and 2 placebo non-responders from placebo responders. And so to give a magnitude size, if we had used a conventional design, we would have needed about 240 subjects versus 195 with the SPCD. So that is substantial, right? Because it allows for trials to be conducted faster, more fiscally proficient. The downside is that then there are some subjects that get placebo. The upside is it's a true placebo, and there might be some that actually respond to placebo. And for acute pain research, the placebo rate is as high as 35%. So that's not negligible. And the least we want to do is introduce a medication, say that it helps, and then it might be the procedure that helped or whatever else factors that plays into a placebo response.
Back to the clinical trial as a study design had. And then what is meaningful? Okay, pain control is meaningful. This is the whole point of the trial, right? But we talk about that people have different trajectories of pain. That is the one thing that is really hard to measure. Okay, what else is meaningful? What if someone is actually on adequate control of pain, but is taking a ridiculous amount of opioid to get there? So could we actually reduce that? Is that impactful? And we know it is impactful because patients that have been prescribed opioids, appropriately so, are at much higher risk of ultimately developing addiction and or opioid misuse, which is like, again, diverting opioids to the community. So then we felt that we wanted to be patient-centric when choosing the endpoints for this study. But we also needed to be pragmatic and decide which would be meaningful enough from a patient perspective, but public health perspective too, that will be also meaningful and easy to measure in a pragmatic approach. So efficacy primary endpoint is actually a standardized way of measuring opioids, so oral morphine equivalents a day, within 24 hours after each PPF injection is spanning the 48 hours because that's how SPCD design analysis. And then we talked about all the TCD data, right? We want to make sure that it is safe. The rate of complications in our hands here and elsewhere, it is tiny little oozing over here for the procedure, and maybe every time that you poke someone, there's a risk of infection, but this is negligible too. What else can potentially be a safety threat? Well, modulating the SPG, right? And then modulating the cerebral vasculature, increasing the risk of vasospasm. So then primary safety endpoint is that we know the PPF injections and blocks are safe in the general population that needs them, but is it safe in subarachnoid hemorrhage? And hence, that's how we got there. And then, is it tolerable? What if it works, right? And then it's safe, But people are like, are you kidding me? Like what it takes for me to be pain-free and opioid-free is needle in the face. I don't want that, right? So then we want to demonstrate that it's actually not bad, not bad enough. Like I don't think my picture getting the needle in the face is enough to prove that it is tolerable. So then we are actually doing that in a systematic way with the rates of acceptance of a second injection at 24 hours. So they are more like they're already experiencing it and they're still wanting to do it again, even if it is actually not knowing whether or not it's something that is potentially helpful at that point, right? Because it's blind. But there are so many more things. This is such a rich data set, and it was really hard, right? Really hard to choose the secondary endpoint. And we wanted to collect everything. So the pain is important. We gotta keep track of that, right? If people are not giving opioids just because of the effect of being studied for giving opioids or not, right? So then the pain needed to be studied. So that is the secondary efficacy. And safety, for any early trial, you need to really collect everything in a nuanced, granular way. So then any changes, even if they are not clinically significant, but radiographically significant, we wanted to keep track of that. And again, tolerability also, the agreement of subsequent multiple active PPF injections. And there are so many other exciting data points, right? So opioid use during the hospitalization, what if we can actually control the pain early on? Does that have an impact on the trajectory of pain? So how does that actually affect the rate of use of opioids? How does that affect hour to hour? How long does this pain control actually lasts, right? So then the hourly pain scores. What other medications? Maybe the sodium is actually better. And those patients are not requiring as much hypertonic therapy or fludrocortisone to maintain sodium levels, right? So there are so many other impacts. And this is an important slide that I want to just have it there. Because again, the whole point of this talk is to identify with this. How can we leverage, right, the $13 million that our institution were awarded to run this and to maximize the scientific output together as a community, building together with brain, right? So is there any interest in all these data sets? Is there any ancillary study that you were thinking that we could actually use merging your expertise with this machine that it is BLOCK-SAH in collecting all these data, right? And that for paying investigators, for diversity and disparities in research and in neurodisparities science investigators, this is super important because there are individual variations in pain perception, in the tolerability to procedures. So then it is really a rich opportunity for us to combine expertise together and leverage this infrastructure to just, again, optimize the scientific output that we can have.
And so just as food for thought, this has nothing to do now with BLOCK-SAH proper. I just want to put out some things that we thought about when we think outside the box, what else could there be, right? But this is not part of the data set as of now. So interleukin-6, I mentioned earlier, inflammation has been implicated a lot with both delayed cerebral ischemia and also headache creation. Interleukin-6 is part of the inflammatory response after subarachnoid hemorrhage. It has elevated serum and CSF levels. Could there be else that we could use our data set for? Metabolic alterations. So we do know that the CSF metabolome post-subarachnoid hemorrhage is altered, which reflects a disruption of the normal metabolic pathway due to the hemorrhage and due to the ongoing secondary injury. However, we don't know exactly how this might relate to the pathophysiology and for the pathology that we see with headaches in post-subarachnoid hemorrhage headaches. And then neurochemical changes that have been described with headaches are alterations with both gamma-aminobutyric acid or glutamate. Again, this is thinking far outside the box for the ones among you that might be more venture-oriented and have some ideas along these elements. And then vasospasm and autoregulation, we mentioned this abundantly because this is the best studied in clinical medicine. Now, even in bench and translational endothelial dysfunction, again, the concept of inflammation has been mentioned quite a bit. There is a reduced production of vasoactive substances such as nitric oxide. and increase the expression of adhesion molecules. There is complicated interplays between vasospasm and impaired autoregulation. And then the cyto and chemokines again play a role, which may alter vessel reactivity. Again, this is food for thought. It is outside of BLOCK-SAH in the hopes with the incentive that someone might join in to think about what else could we do with this data set that we already have.
Then you probably want to know who are these people that were targeted to enroll, right? So you can actually think if that is suitable to the ideas that you're having. So essentially, inclusion criteria, this is the eligibility criteria, need to fulfill all inclusion criteria, none of the exclusion criteria, and able to give informed consent that is a given. You can see that we are very pragmatic, so broad representation for age. And then subarachnoid is specific. So we wanted to be a homogeneous there, and anyone that will actually have a aneurysm or spontaneous subarachnoid hemorrhage, that it is able to verbalize pain scores. So we know that a segment of this patient population can be too sick to be awake and even manifest pain. So it wouldn't be able to actually measure the primary endpoints, the secondary endpoints appropriately if we didn't fulfill this subarachnoid specific criteria. We want to do it in a safe way. So after the aneurysm is successfully secured and by the eyes of the surgeon, and then again, going back to able to verbalize pain intensity scores, they need to have a headache for which they are requiring opioids. In order to qualify, we needed to be arbitrary in the decision of how much opioid, but if it's like 0 or 5, how can we potentially demonstrate the effect? This is arbitrary and pragmatic approach to that. Now, and we want to make it safe. If they cannot tolerate any of the components of the standardized headache management or of the components of the active block, they are not eligible. And then if there is anything that make it potentially a higher risk for vasospasm or stroke, regardless of the etiology of the narrowing of the vessels before the intervention, they are also non-eligible. And because you can have a subarachnoid hemorrhage from even from an aneurysm of other etiologies other than a berry aneurysm, or without an aneurysm in the setting of trauma, that adds another complexity into the pathophysiology of the pain that is already multifactorial. So those are excluded at this point. That is not to say that this therapy does not necessarily have a potential for helping those patients. Again, every time that you want to poke someone, you want to make sure that they don't have an increased risk of bleeding. So the coagulopathy that it is unable to be corrected is something that is an exclusion criteria. And as usual, vulnerable patient population are excluded and not adequately represented in many studies.
And honestly, that concludes our presentation on our trial. We want to acknowledge our whole entire team. It includes, not depicted here simply for the lack of spaces, our entire division, our entire neuro ICU, the nurses, the staff, but then our sites that you can see here, who is a site for the trial, and then our local team, which is our scholar team, our coordinator and project management team, and our statisticians from UF as well. Couldn't do it without. It takes literally a big village. And with that, if anyone has any ideas or would like to meet and discuss, the QR code leads you right to the source that will book meetings for you. We would like to thank you for the opportunity and the attention and answer any questions if there are.
Questions? Anything on the chat?
I'll make a comment. I'm very impressed by the commitment of the researchers seeing you having that procedure yourself.
Oh, that's good. Yeah, it was what it takes. I actually was curious to see if
how does it feel, and then if there is anything that we needed to modify in the approach. And honestly, we did, right? We made a lot of changes in how it felt. So based on how it felt, you feel like, and it was without local, right? So then as the needle is advancing, you do not feel pain. You feel a little bit of a pressure. So then I was very calm, not only because I knew what was going on, but Cam was saying, okay, so now you're going to feel a little bit of pressure. You will see that the pressure is migrating close to the top of your palate. So then just by hearing him saying that and then experiencing gave me so much security that I was safe and all the weird stuff that I was experiencing was expected. And based on that, we actually modified the whole way that every proceduralist in every single site in their guidance, it is that they have to go and speak out loud, step by step. So it was really an attempt to do a patient-centric approach to this. So we had some good insights and enthusiasm. And I was curious.
I have a question. Have you been also measuring the facial temperatures after the blocks? Because for sphenopalatine ganglion blocks, it's like, well, because it doesn't always need to be invasive. Sphenopalatine ganglion blocks can be done intranasally. And that's like one of the measures that we use to confirm that the block is successful. Has it also been checked during the
I love the question about the non-invasive way. Thank you for asking this question. All right, Katina, have we considered alternatives and then we can get temperature?
Yes, so the nasal way, we particularly did not choose for two reasons. Number one, it is profoundly uncomfortable, as we know from COVID testing, right? That goes the same direction. And then more importantly, though, for a clinical trial, it cannot be standardized because it's a swab. You have no idea what goes and transfuses through. And then conventionally, the local method is only used with any anesthetics, but usually not with dexamethasone. So it's usually only ropivacaine or bupivacaine or whichever. So for the reason of standardizing and discomfort, we did not use that. And I think the second question you asked, do we check the distribution in the face?
Yeah, that was my
sensation.
question actually. Yeah, the facial temperature, because that's a sort of a standard method of like confirming that the block was successful to compare the sites.
Right.
After the sphenopalatine.
We do not measure temperature. There's also various considerations. Number one, temperature regulation in acute brain injury is disturbed. So 3 out of 4 patients in the first 3 days of an ICU stay are febrile. And then it is because of hypothalamic disturbance. So it's random. It is not infectious fever. So it's complicated. That's the first one. Second one is we did not want to dwell too much on active versus non-active because we have a blinded pathway. So then what we chose to do is to check sensation, which is kind of part of the neurological exam, but not to dwell too long.
Yeah, and that's the thing, right? So technically, with saline alone, it's a 5 cc's injection into a very tiny space. Could the saline alone lead to a partial effect of just by neuropraxia, right? Like a compression a little bit. So we were thinking that, well, we don't really know what is the effect of saline in this patient population because it has never been studied in an awake patient. And we wanted to be objective, and I understand your thought process on the temperature because then it is an objective measure, right? You cannot really say, oh, I feel it or I don't feel it. So that is really, really savvy. But the question, in addition to the hypothalamic dysregulation that then will potentially mask or add a variable to this patient population that it is not present in yours, is the ability to then, if it was saline, it does not mean that it was in the right place, right? Because you just do not know what is the effect. So in order to confirm that it was in the right place, regardless of what it was, the injectate, let's put it this way, we have direct visualization that it was placed in the right place. Because we do not know what it would be the effect of the saline. And as you know, in group 3, it was saline, right? So then let's say that even if it were, let's say that the hypothalamic dysfunction was not a factor here, right? And then you do not have central hyperthermia, as Katarina was pointing out. The fact that you do not have a change in the temperature between sites before switching sites, right? This is bilateral injection, so that also plays a role. But even if you do not have a change, you do not know if it is because saline would not have caused a change, or if you do not know if it is improper placement. So we chose something that, in addition to not being uncomfortable with the swabs, target not only the sphenopalatine ganglia, but also the maxillary branch, which the nasal swab does not target, right? Those two structures is exclusively SPG. But in addition, it's objective enough that anyone blinded to what it is the injection will know for a fact that it is properly. Does that answer your question?
Yeah.
It's a really cool question. I
Different
actually did not know about the.
Yeah, I mean, it's sort of commonplace, I guess, because it really helps. Actually, one follow-up question that I had, Dr. Masia, to that was about the injection of dexamethasone. Because in the pain world, when we do like epidural steroid injections, as Dr. Smith also mentioned, mostly the steroids, we expect the steroid pain relief effects to present after sometimes a couple of days, sometimes a few days. And given that here the cross group is like, placebo, steroid, and then steroid placebo, how would you differentiate the like pain relief data points? Because, like, for example, the steroid day 1 and then placebo day 2 group, they might very well have a pain relief effect on day 2 because of the steroids effect on day 2, which is actually when we would expect the steroid to act on, not immediately, but after a couple of days. So how have you been like differentiating that pain relief effect between the cross groups?
We talked about the carryover effect potentially from day 1 to day 2, and we even considered we need to space out a little bit more. And it was a challenging decision based on that. And it brings me an important point to clarify that
You want the anesthetic to do the block, but then the anesthetic doesn't last. The role of dexamethasone is actually to prolong the duration of the block, hence your question, right? So the role is the anesthetic to kick in and increase the duration of the block. So the way that we felt with the placebo, comparing the placebo non-responders and responders, we thought that design could potentially account for a potential carryover effect. Now, to be honest, we did not think you would prolong too much the duration based on what we noticed from our patient population, that we do this clinically, as you know, in our hospital for patients that have refractory pain. And oftentimes, even in the setting of bupivacaine and dexamethasone, there was a rebound, an increase in like a rebound in the pain after 24 hours. So we felt that it is possible that the carryover effect will not be so homogeneous and so high to be able to jeopardize the power to detect a clinical effect. Make sense?
Yeah, I think additionally, the other piece is that honestly, from a clinical perspective, whether they get the dexamethasone on day 1 or 2, then makes less of a change, honestly. And so then in our secondary and exploratory outcomes, we are catching that tail end, which would be compared to placebo, do you need less opioids throughout hospitalization?
So Dr. Wiesel, so between, if I remember correctly,
Do you want to look at the design?
so do you have the, like, in your data, do you have the capability to like compare group 1, like more correctly, day 1 of group 1? So will you be able to compare A to D? Because I think that would be a good comparison of, in order to assess carryover effect from the, like from the injection. Sorry, not day to D, B to C. So if like the group B has, like more pain relief when compared to group C on day 2.
this is what you're thinking, right?
No,
D to C.
So group 1 on day 2 to group 2 on day 1. I think their comparison would be very interesting from my perspective to see, not only for like this study, but I think for like any pain study. because it would show, how the steroids like has, like what would be the carryover effect if there is no difference.
Right, right. I mean, I think most definitely, so are we able to, we can do all kinds of subgroup.
Yeah, I think that would be super,
Um,
super interesting.
Yes, minus the fact that for subarachnoid, you will have a change. Again, the problem is that it's not static, right? Day one is not the same as day two because they're closer to vasospasm. So there, it would remain exploratory, but absolutely.
All right,
You see
that
groupified
sounds very
signal,
interesting.
most definitely.
Thank you very much.
So we are saying, comparing, can you say that one more time? I want to say one more time, point it out, I wanna.
I'm just concerned that, like, the select from the day one group one group, I think can have a good carryover effect to day two group
Yes,
one
yes.
data. But if we can compare that to group two day one data, then it would give us to what extent there is a carryover effect versus not. I think it's an interesting data point.
Yeah,
Because, also outside the study, it also tells us like how much the dexamethasone might be changing the next day's like outcomes. That's what
yes,
it's a
And
great-
even, right, and even just to, and then do as a confirmatory, the comparison that you said, but also the pain on those that received, those on group 3 that got only placebo, and then finally got active, and actually see how they're feeling a day after the active they received.
Sure.
After receiving placebo, so then it is really, like not the injection, it is actually truly, what it is, the injectate.
thank you.
No, thank you. I mean, that's a great design.
Else?
Well, Ruthie, the QR code was your email, so that you guys can email Ruthie and schedule meetings with us, ideas and how you would like to actually drive the collaboration. Because again, this is about the community of the village and expanding on the scientific output, leveraging the resources available to us. Thank you.